all be known, right? I let it be known that there's going to be breaks built in, that we can stop at those points for questions, but also that any time during the presentation, if they have a question, feel free to stop me, because I know the material, you're not going to mess me up. I want to make sure that the questions are being answered as they're coming in. So I don't know what you know about the program or with anesthesia, but one of the things that I do before I even do the presentation is this is how I begin. Hey guys, thank you very much for having me today. I know your time is valuable. I promise I won't waste it. Before I get into the presentation, if you look at all the different programs and all the different service lines, they do things slightly different. So before I go into the data with Ingesto and what I want to present to you today, I want to ask you a few questions about what you guys are doing with your current protocols, because this way I'll be able to tailor this presentation more to what you guys are doing and make it valuable not only for you as clinicians, but also what you're doing as an institution. So the first ask is, with your total joints, what's your current protocol, right? And then Bobby, they're going to say something like, oh yeah, like, well, actually I'll say, with your inpatient and your outpatient total joints, what are your current protocols, right? And then you may get a little hem and haw, and then you just get proactive, and you're like, do you guys preload with Celebrex? Oh, okay, you preload with Celebrex. Do you guys use Toradol in order to bridge them through? Okay. Are you guys using any ketamine? No? All right, no worries. Fentanyl? Yeah. Bupivacaine, lidocaine, right? And then they're going to give you the answers to that, and then that can help. You're going to say the same information in the presentation, but you're also tailoring it to what they need, right? So the first slide, I know that this looks boring and it looks generic, but this is actually, it tells the tale of what I'm here to talk to you about today. So when you look at Ingesto, what is Ingesto? Ingesto is a once daily non-opioid IV analgesic. All right, well, what's the big deal behind that? Well, when you think about it, every pain protocol that exists today is actually trying to accomplish this. Right? They're trying to accomplish 24-hour coverage with zero gaps, with the least amount of narcotics, in a formulation that is full and works for what you are trying to accomplish, right? And we'll get to that a little bit later. So when you're looking at this, the reason why you guys have not been able to use one particular product, and the reason why you're seeing that when you're looking at protocols, especially on the non-narcotic side, that you'll throw acetaminophen, you'll throw Toradol, you'll throw Celebrex at it, is because up until this point, you didn't actually have a tool that accomplished or had this kind of clinical profile. In order to achieve this clinical profile, you had to either dose a product multiple times, you had to use multiple products, and you also had to make compromises on the formulations of those products and how to work around that. So if there's one slide that you remember out of this whole entire presentation, it is this slide. And the reason for that is that this slide gives the clinical attributes of Ingesto that is the foundation for all the data points that I'm going to be showing you later. And it's also the foundation for what we're seeing, where need is in the actual community outside of a controlled clinical environment, and why they're seeing a benefit from it. So the first thing that jumps is that Ingesto lasts 24 hours. One dose lasts 24 hours. This has implications both on the inpatient and the outpatient side. On the outpatient side, your focus is you have to get the patient up and ambulating as quick as possible. You got to get them comfortable. You got to get them through assisted and independent ambulation. Then you got to get them out the door. But once you get them out the door, it doesn't stop there. You actually need the coverage to last 24 hours to keep them from coming back, or to keep them coming back to the ED. And that's where this 24-hour coverage comes into place with Ingesto, because when you're looking at current protocols, you either have variability in onset due to formulations, or you're going to have gaps due to the length of duration and what's going on. So a perfect example of that is in total joints, you can have a situation where you're preloading with Celebrex, right? Celebrex is a PO formulation. You know it's going to be variable in how it goes into the patient. That's why you're using Toradol in order to get them through that PACU phase 1, phase 2 stage. Once the patient gets discharged, you only have Toradol on board for 6 hours. Now you're at the point where you're at the mercy of how long are the blocks going to last? Will Celebrex get on in time? And if it doesn't, that's when you're in a situation with callbacks. With Ingesto, you know that once you dose it, it has Tmax of 6.5 minutes, but then you also get coverage for the next 24 hours. So that gives you the coverage where once the patient is discharged, you comfortable at home. And then when they're transitioning over to the POs, you know that they're covered with no gaps in between that. The second point is that it has a demonstrated safety and tolerability profile. This is IV meloxicam. Meloxicam as a molecule has been on the market for 20 years. There's no surprises with that. You guys are very familiar with it. The difference is that now we're dealing with a different formulation that is more designed for an acute care setting. The third point is that it's COX-2 preferential. Now, this can go either way. I've seen it where surgeons really, really want a COX-2 versus a COX-1. I've seen others where people don't really care if it's a COX-1 or a COX-2. But we'll get into the differences in between the COX-1 and the COX-2s and the potential impacts that that's going to have on certain patient populations that you're going to be treating. And then the final point is that it's a once daily push. Their eyes at anesthesia should be lighting up. And I always say, you know, the running joke that I used to have is that when I was dealing with anesthesia, you guys won't push anything, right? So, but at least this way, you guys can now, in the label, you can actually push this. But the other thing to consider is that there's no mg per kg calculations. There's no dose adjustment for patients who have mild renal insufficiency. You're not dealing with any special tubing. You're not dealing with any pumps. You don't have to run it in over 15 minutes because you're worried about Redmonds or other onset issues that are going with it. And it's literally take it out of the vial, put it in the port. It's in the patient. You have Tmax in 6.5 minutes later. So obviously, you're not allowed to say this, Bobby, but sometimes I say, like, you know, all right, on to the lawyer slides. But this is actually important safety information that concerns Ingesto. Because the first thing that we're going to talk about is we're going to talk about the indication, we're going to talk about the warnings, and then we're going to talk about some contraindications. So the indication for Ingesto is pretty simple. It's indicated for the use in adults for the management of moderate to severe pain, alone or in combination with non-NSAID analgesics. If you look at it, box warning, that's across the class, both on the cardiovascular and gastrointestinal side. And when you're looking at the contraindications, it's known hypersensitivity to meloxicam or any component of the drug, history of asthma, urticaria, or other allergic type reactions after taking aspirin or other NSAIDs, in the setting of CABG, and in moderate to severe renal insufficient patients who are at the risk of renal failure due to volume depletion. That whole statement is the contraindication. If a patient is moderate to renally insufficient, but they are not at a risk of renal failure due to volume depletion, it is actually a warning. So, continuing on with the warning and precautions, you have, once again, across the class, hepatotoxicity, hypertension, heart failure and edema, post-MI patients, renal toxicity, anaphylaxis reactions, exacerbation of asthma-related aspirin sensitivity, serious skin reactions, drug reactions to eosinophil or other systemic systems, hematological toxicity, fetal toxicity, and then also drugs that interfere with hemostasis, warfarin, aspirin, SSRIs, SNRIs, ACEs and ARBs, diuretics. So finally, when it comes to pregnancy and infertility, you have a class warning associated with that goes with all the other NSAIDs as well. So at this point, this is one of the built-in stops. As soon as you get to this slide, stop, take a breath, and be like, are there any questions, right? You guys have any questions on anything that you've seen or anything like that? Pause for a second. If they get a question, answer the question. If there's no questions, be like, okay, let's continue on, all right? So when you're looking at the overall profile of IV meloxicam and Ingesto, we touch upon some of these things. So once again, as a molecule, meloxicam has been on the market for over 20 years, right? When you're looking at the dose ranges are anywhere from 7.5 to 15, can go up from there. Tmax is about 5 to 6 hours. But when you're looking at Ingesto, it permits the IV administration of immediate systemic availability. And when I say immediate, Tmax is in about 7.5 minutes. So when you're looking at the differences between the COX-1s and the COX-2s, one thing that you got to remember is that there was a time where COX-2s did not exist, right? So the only thing that you had were COX-1s. And one of the reasons why when COX-2s came to the market, they were so successful so quickly is because they were able to address the pain component that the COX-1s have without some of the drawbacks that are associated with it. And when you think about COX-1s and those drawbacks, a couple of things immediately come to mind. The effect that they have on the kidneys, the effect that they have on the GI tract, the effect that they can potentially have on platelet function. And then on the COX-2s, what you have is that they address pain, inflammation, fever, but they also have those limited hemostatic effects. And this can be pretty much demonstrated when you look at the affinity of the different molecules and where they go at according to their COX selectivity. So obviously on the right-hand side, you got ketorolac, you got aspirin, you got ibuprofen. And when you think about the side effect profiles with all those, it should pretty much jump out at you what's common across that class. Then you switch over to meloxicam, Vioxx, Celebrex, and diclofenac, and once again, you start to see a skew away from those common side effects that you associate with COX ones. And when you're looking at it, it goes back to that question, right? Why an IV versus a PO? Now, some of this has been, done and dusted, taken care of, but it goes back to the appropriate formulation for the appropriate point of care for your patients, right? Meloxicam in the PO formulation, Celebrex in the PO formulation, they all work, right? But when you're looking at it from trying to address the patient in an acute care setting or when they're in acute phase of their pain, that's when the IVs come into play. And you can even look at it at the current protocols and what they're trying to accomplish. They're preloading with Celebrex, which is a PO. But since it's a PO, you don't know when it's going to go systemic, especially when you have the impacts of other narcotics, the effect on gastrointestinal function as a result of the patient going through surgery. But even under normal circumstances in healthy volunteers, you can look at Tmax being in about 5 to 6 hours with an oral, right? That doesn't cut it when you're doing same-day surgery. You need the patient covered in the PACU setting, and you need to get them ambulated and up and out the door. And that's a big reason why people are using Toradol in order to cover that, is because you need an IV medication in that point in time. And Bobby, I'm going to stop right here. This is just something for you to think about. Be careful on how you say this. Be comfortable if you are going to go there, right? I say, if you guys are not familiar with this, there's actually an oral formulation of Toradol, right? And to give you an idea, you guys have a choice between oral Toradol and IV Toradol, and you're choosing IV Toradol all the time, right? But more importantly, you're choosing oral Celebrex overall, right? Because you want to get away from that profile that Toradol has so much, right? So that's just something for you, Bobby, for you to keep in the back of your mind. There is an oral formulation of Toradol, and nobody uses it, right? And the reason why they don't use it is because of this, right? So because it costs just as much as the IV, but they're going to use the IV because they need it on board as quick as possible. So when you look at the PK profile of IV meloxicam versus PO meloxicam, the story speaks for itself, right? So the trough levels of IV meloxicam never get below the peak levels of oral meloxicam. But more importantly, with the time period that you are going to be interacting with the patient, look at the curve, right? So from 0 to 6 to 0 to 8 hours, you get a dump into the system, and then it stays elevated in that system during that whole entire time. But just as importantly, it continues on through that whole entire 24 hours, right? Which is at the point that the patients are naturally going to be switching over to PO formulations or at home. But you're minimizing the ability, or you're minimizing the possibility of them either having to go back to the ER to get readmitted, to go back to the ER looking for pain, you guys getting the phone calls for pain. And this is all based upon this PK profile. So when you look at the range of surgical procedures that we studied in, pretty broad range. It's going to be broken up into two different settings. So one is going to be our phase 3B data. That's post-marketing, excuse me. And then the other is going to be our phase 3 data, which is the data that we used in order to not only get our indication, but also to get our approval. So the first thing we're going to start out with is the phase 3 data. So what is really, really cool about this data is that not only is there a safety component to it, there's an efficacy component to it, but there's also a healthcare economic component to it. And we are allowed to give you that data, which has actually been a change, right? So there was a time where they would not allow us to present that data, and only quality would be able to get this data. And the data is really good. So the first thing is that when you look at how the trials are structured, the trials are structured pretty real world, right? So the patients are able to get gabapentin, they're able to get acetaminophen, either IV or PO, they're able to get narcotics, and then they're able to get narcotics and acetaminophen on the back end. So this trial, it's when you're looking at our phase 3B data, it's broken down into two components, same with our phase 3 data, and that is going to be hard tissue and soft tissue. Soft tissues on the colorectal side, hard tissues in total knees. Bobby, do you need me to stop?
No, you're good, dude.
All right. Well, that's the other thing. When you're doing the presentation, keep an eye and looking at people. So I was just watching you. Yeah. So
my girlfriend was moving some dishes in the kitchen.
I can't hear it. I can't hear it. Yeah. This data is on the soft tissue side of things. So on the colorectal, you're talking about full resections, big cases. You're putting in ostomies. They're also doing bags and everything along those lines. And this is how it was structured. So when you're looking at the primary endpoint is safety and tolerability. Secondary endpoints is the use of opioid analgesia, time to bowel function recovery, and then also length of stay. So the major takeaways that they were able to find is that it was shorter time to bowel function recovery, the overall rates of AEs were lower than placebo, and then a reduced length of stay by 1 day, right? And I actually have a real world example of what this means, right? So a couple years ago, I get a text message from my friend. My friend texts me, he says, you can have my motorcycle, I'm getting prepped for emergency surgery. If I don't make it, the motorcycle's yours. Of course, I'm like, what the hell, right? So I immediately text him back. Turns out he had diverticulitis that he wasn't taking care of. He ended up herping his bowel. He had to have an emergency resection, right? They went in, opened him up from stem to sternum. They removed 10 inches of his colon, right? And then he got a colostomy bag for good measure. Now, his wife is a former ICU nurse. He works in industry also. So these are people who are very savvy as patients, right? The hospital that he was at, this is down in North Carolina, they actually had an ERAS protocol, but it turned out in that particular hospital for this particular service line, the ERAS protocol involved a lot of narcotics, right? So he's post-op at coming to grips with his new reality. The narcotics have completely shut down his bowel function, right? But on top of it, he's still in a lot of pain, right? So I get a call from his wife because she knew that I used to work specifically with colorectal surgeons, especially on the non-narcotic perioperative pain side. And she asked me what they were doing, and I told her that they were alternating NSAIDs, basically, acetaminophen, Toradol. In this particular case, it would be acetaminophen and Ingesto, and that those guys almost 10 years ago were able to virtually eliminate narcotics as well as PCAs, and then that had a direct impact on their discharge times, where they're able to get patients discharged in 2 to 3 days. So I suggested that she talk to her surgeon, right, and see if that was a possibility. She talked to the surgeon. They immediately switched him over to an NSAID-based protocol and started reducing the amount of narcotics. Now, originally, because all he wanted to do was get out of the hospital, he's asking when's his discharge times, when is discharge times. They were giving him an estimate of 7 to 10 days, and that 7 to 10 days was dependent upon his bowel sounds and bowel function, which were non-existent at that point. So within 24 hours of them switching him over to an NSAID-based approach, he started getting bowel sounds and bowel function back, and his discharge time went from 7 to 10 days to where he was discharged in 4 days. So when you're looking at the components of this, these are real-world metrics that they're using and how the clinicians are going to judge whether or not the patients can get out. And as you guys are very much well aware of, if you can reduce length of stay, you can reduce, especially with major cases like that, that has a direct cost savings to the hospital. So when you're looking at it specifically with Ingesto, now remember, when you are looking at placebo in this, placebo is ERAS, which is what I showed you in the beginning, which is gabapentin, acetaminophen, narcotics, right? So that is not Ingesto versus placebo. That is Ingesto versus an ERAS protocol. The only difference is that one had Ingesto and the other did not. So the first thing that jumps out at you is bowel sounds, right? Bowel sounds went from 22 hours to 9 hours. If you're looking at flatus, went from 50 hours to 38 hours, which is a full half day. And then when you're actually looking at bowel movements went from 62 hours to 52 hours, which is also almost half a day, right?
BT, that's ERAS. Hold on, real quick. That's ERAS plus Ingesto. They're not taking away anything and replacing it with Ingesto, right?
Right, they're not taking. But the thing that you got to be careful with is that they don't have Toradol on their on the control arm, right? So it's ERAS without an NSAID, right?
Okay.
Versus ERAS with an NSAID.
Okay.
Right, but it still doesn't change the fact that in order for them to get that results with Toradol, they're going to have to run Toradol around the clock, right? And so one of the things that you can say is that if they're like, oh, but that's not against Toradol, right? And Bobby, I'm telling you, this has not come up once, right?
Yeah.
Never asked me this question. But if they do ask that question, what you can say is, yeah, we couldn't do it because there's no way to run a comparator trial when you're dealing with something that's dosed every 4 to 6 hours versus something that's dosed 24 hours. Where are you going to take the pain components? If you take it every 6 hours, then that means, depending upon when the nurse comes in, it's either when the patient is at their peak level or at their trough level, which does not give you an accurate indication. Besides the fact, in today's environment, especially with what's going on with this new variant, you're now going to be in a situation where, once again, they're going to be looking to minimize nursing contacts with the patients. And you won't be able to do that with a drug that's dosed 4 to 6 hours versus one that's dosed 24 hours. So when you're looking at the side effect profile, it starts to bear out because look at the nausea rates. It was 33% in the Injesto arm versus 50% in the ERAS arm. But just as importantly, look at the ileus rates, right? The ileus rates are 3.7 in the Injesto arm versus 17.9% in the control arm, right? One thing that you need to take into consideration when you're looking at those ileus rates is that Interreg was not allowed in either arm. There was no gut stimulants that were allowed in either arm of the trial. So when you're looking at those ileus rates, that is not ERAS plus gut stimulant. That is Injesto, the impact that it has compared to the control arm. So what did this all mean? Overall, they saw a reduction in length of stay by 1.1 days, and they were looking at a lower adjusted median hospital cost of $2,190. So when you're switching over to the hard tissue side of things, the trial is structured very similarly. So patients were able to get gabapentin, they're able to get acetaminophen, either IV or PM. They're also able to get bupivacaine, either intraspinal or infiltration, and they're able to get IV narcotics, oral narcotics, acetaminophen, and then aspirin per investigator for venous thrombosis prophylaxis. When you're looking at the primary endpoints on this, when you're looking at the colorectal side, the primary endpoints had to focus around safety as well as the healthcare economic costs. With this, there's actually an efficacy component involved with it as well, because we're looking at the sum pain intensity score, as well as the safety and tolerability and the length of stay of the patients in the hospital. So the main takeaways: significantly lower pain, rates of AEs were lower than placebo, and then you reduce post-discharge resource utilization. Oops, sorry, skip. This slide is the reason why we're seeing the uptake that we're seeing in an outpatient setting, right? And given, once again, the environment that we're in, you've seen a migration to more outpatient surgeries. Even if those outpatient surgeries are patients coming into the hospital, using the ORs in the hospital and being classified as outpatient when they're only staying 23 hours and then being discharged, you're seeing that migration. And a big reason why you're seeing some changes in the protocols where they're implementing Injesto is because they know during the whole entire phases that they're going through with that outpatient setting, the patient is covered. So when you're looking at it, overall for the first 24 hours, you have a reduction in pain of 22%. During the assisted ambulation phase, you have a reduction in pain of 33%, and during the independent ambulation phase, you have a reduction of 37%. The reason why this is significant is because when you look at the evolution of total joints, 20 years ago, if I would have told you that you were doing outpatient total joints, you would have told me that I'm insane, right? And the big reason why outpatient total joints are possible, you have changes in surgical techniques, no doubt. You have changes in block strategies and how blocks are utilized. But the biggest reason is because you were able to use non-narcotics as a foundational approach for your perioperative pain management. Because you cannot have patients up and ambulating if they're on high-dose narcotics immediately post-surgery. But you can't reduce those narcotics unless the non-narcotics that you're using actually can address the pain. And so when you look at a slide like this, that is a big reason why we're seeing the uptake that we're seeing, especially in the outpatient side on the total joints. It's because you have a reduction of 33% pain during the assisted ambulation, a reduction of 37% pain during the independent ambulation, and over the first 24 hours, imperative that those patients either come back, you have a reduction in pain of 22%. So overall, when you look at the side effect profile, as I was saying, the side effect profile, it was lower in the Ingesto arm versus the placebo arm. And all this adds up to what I affectionately refer to as the money slide. So it's patients overall experienced 33% less pain. Patients were ready for discharge 4 hours earlier. That is not, and it's not statistically significant because the trial wasn't powered for that. But overall, the patients were ready 4 hours earlier. When you're looking at surgery and discharge, it's the overall hospital costs were $2,519 lower. But look at over on the right side and what that means tangibly for what happens afterwards. In the Ingesto arm, there are few patients requiring SNFs. There are fewer hospital readmits. There are fewer ER visits due to pain. And there are fewer phone calls due to pain. And that is directly related to the fact that the patients were covered for 24 hours and you didn't have gaps in their coverage. So at this point, I'm going to stop. That is the phase 3B data, and see if you guys have any questions. No questions? All right. Let's move on to the phase 3 trials. These trials are structured a little bit differently.
BT, let me ask you something, dude. Let me ask you something, dude.
Say again?
You think it's necessary to go through this too? I'm just looking at the time, and I only have like 30, little over 30 minutes if I push it, and Kevin has to do his slides as well.
All right. So here's the thing, right? Where are we at right now?
26.
All right. So skip the phase 3, right? Just be like, hey, in the interest of time, going to skip the phase 3 data. Just know that this data is what got us our indication and our approval, right? And we can set it up where I can come back in and do another lunch and I can go through this data with you, but I want to make sure that Kevin has enough time in order to do his thing.
Okay.
So that brings us to the final point, right? And I don't know if you want to go there. You can talk to Kevin about this, but anyways. So why consider Ingesto for your, right? So first is evidence-based guidelines and what they're designed to do. They're designed to improve patient outcomes because it's as simple as this. You have good outcomes, it costs less to treat the patient. You have bad outcomes, it costs more to treat the patient. And ERAS protocols and everything that was the migration over from narcotics to non-narcotics, that's all centered around this principle. Multimodal analgesia is just simply put designed to improve patient outcomes, which is designed to actually save everybody money. It's designed to make your life easier, designed to make the patient's life better, and it's designed to save the hospital money so that they can make more money, right? And as a result of that, NSAIDs are recommended in multimodal analgesia across a ton of different academies and a ton of different societies. You guys are anesthesiologists, you know without a doubt that the American Society of Anesthesiologists, the American Society of Regional Anesthesiologists and Pain Medicines, all those guys, they recommend multimodal analgesia. So when you're looking at how it breaks down and why that is, in an inpatient setting, it's very simple. Non-opioid option aligns with hospital opioid stewardship goals. Once daily dosing, and it reduces the frequency of analgesic dosing. Patients are ready for discharge earlier. There's lower mean hospital costs associated with our phase 3B data. And then there are few discharges to SNFs, readmissions, and ER visits in our total need data. When you're looking at it from the outpatient side, administration of opioids increase the risk of sedation and respiratory depression. That can affect, especially on lower extremity ambulation. Ingesto rates of nausea and vomiting are similar to placebo. You have an up to 24-hour duration of pain relief, and they may cover patients' travel home as well as the first night after discharge. You have fewer post-discharge phone calls related to pain and total needs. And then Ingesto also has a Medicare pass-through status for procedures in the hospital outpatient pharmacy department as well as the ambulatory surgery center, right? And what do I mean by that? What I mean by that is that for the ambulatory surgery center affiliated with all the hospitals, if it's purchased by the hospital department, all the Medicare patients, you're allowed to bill separately outside the bundle for it, and you're going to get 100% reimbursement. If you're looking at our overall WAC cost is $94 a vial. If you guys are 340B eligible, it's going to be $72. And once again, you have the pass-through status on Medicare, which depending upon who your GPO is, you're probably going to get it for anywhere from $88 to $90. And Medicare is going to be reimbursing at about $97. So I'm going to end my portion of it before I hand it off to Kevin with where we started. The one slide to remember out of all this, because it is the foundation for all of it, is Ingesto, one dose lasts 24 hours. We have a demonstrated safety and tolerability profile. COX-2 preferential IV NSAID, and it's a once daily push. Any questions?
Awesome, man. Thank you. My one question would be, does it ever come up that when you're going through the 3B data that they mention the fact that they're still using opioids within the study?
No, because they're always going to be using opioids. So even there's not, except for colorectal.